Hey, everybody, welcome back. So, today we are going to be talking, obviously, about selecting, administering, and scoring and interpreting assessments. That to me feels like a mouthful and it's going to be a lot, but remember, we're getting more practice either in class or in other assignments. So, we're going to talk very generally about this today. One other thing that I want to mention, because this is something that's coming up in classes, and I know for all of you who are watching who are in the class, you're probably like, well, we hear it in class. Why do we have to hear it here? Part of it is because there are a few people online, and sometimes I tell one class one thing and another class another thing. And so I want to just put this out into the universe for whoever needs to hear it. One of the threads that permeates through this course and through the textbook we're using and many other textbooks on assessment are the science and a little bit of the history. So I want to explain a little of the history in case I didn't mention it. Sorry for those of you that have heard this, it might be a little redundant. Throughout the 20th century, there was a long trend of this, well, I guess maybe for not just for the last 100 years, but the last 2000 years, maybe, there have been trends of increasing scientific investigation. So what that's looked like is we need to have a process through, remember back in like seventh grade, and there was you have to have a hypothesis, and then you have to test your hypothesis, and then you make a theory, and then all that kind of stuff. And then as you get to college, you learn about the research process, which is a little bit bigger, which means that there's professors like myself who do research and then we publish it. And then our peers get to evaluate the science to make sure it's all sound. And then they publish it. And then more people reproduce those studies and that kind of stuff. Like that's how it's supposed to work. And that means that we try to use that same mindset sometimes in counseling. However, maybe it's always been there too for the last 2000 years, but especially starting in like the 60s, 50s, 60s, 70s, there's this humanist movement which says, we're not really quite so interested in dissecting people into these chunks that we can quantify now in numbers. And now that we have computers, we can use data and have bigger data sets and assess more people. It's more of getting back to that, the energies that we share between us and the spirit that people have, and the stuff, whatever that ethereal stuff is that's between people that we look for, whether it's an emotional connection or just trust that exists between us, something about that relationship, which it's hard to put words to, matters. And when we're doing assessments, we're not just looking for specific diagnostic criteria or even sometimes words that we can use in our English language or whatever other language. Sometimes it's just a feeling or a sense that guides us. So when we're doing our assessment work, oftentimes it's, do I understand you? And I'm going to use some lots of different language here to sort of try and take a stab at whatever this might be. It's, am I feeling the energy? Are we in synchronization? Are we in the spirit of healing and wholeness? Are we working in the same space? There's all kinds of different ways of saying it. But that humanist movement does not focus quite so much on selecting a specific test instrument, using that scientific process. There is definitely part of it in there, but these two things kind of blend within each other. That makes it really hard for you guys and us to say, well, what then do we do? Are we scientists? Are we artists? Is this a creative process that's developed between two people and the output is really the product of two minds coming together? Or is it, I'm the expert, I test and assess, make an interpretation and diagnosis, and then you go away with the treatment and we're all good? It's both, and it depends on how you use it. So as I talk about this stuff, this is more of the scientific stuff, and it's easier to talk about because we can write it down and put it in a book. And yet this other thread of humanist understanding of another human being is an important part of what therapy is, can be, and I would argue should be. So anyway, for what it's worth, let's now jump into this, and I'll try and make commentary on both of those threads because I'm finding out as the first few classes that we've gone through, that's really something we need to spend a little bit more time on because it's something you guys are hungry for and probably just need to do it too anyway. So, okay, let me click on the right thing. So, when we talk about these formal assessments, we have a couple options that we can think about. What do we want to do with these? Some of us may want to start collecting relevant tests that we might use in our practice. For example, if you're doing clinical diagnosis in a private practice and that's your future, you're probably going to want to spend time gathering things, tools for depression, anxiety, OCD, panic disorders, social phobias, schizophrenia, etc., 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 etc. You're going to need a list of those things that you can use to test for diagnostic criteria. Now, just so you know, part of an assessment for a lot of people, they don't use the tools specifically. They just ask the questions that they know match the symptoms in the DSM and then go cross reference it by you told me your story. Now I look at the symptoms. Does it match? Then yes, I can make a diagnosis. And not, there's not a tool necessarily that somebody has on a clipboard in front of them that they're making check boxes and scoring and that kind of stuff. But that's still part of the process. I would argue that maybe that's uh, there's nothing wrong with it. There's nothing bad about it, but there's more potential for error. If you remember last week from talking about reliability and validity, we are imperfect beings, and the more we are humble about our limitations, probably the better off we'll be at correcting for those human errors. At least I would think so. But as we talk about administering tests, we'll find out that it's really probably a good idea for us to put systems and processes in place to make sure that we aren't making mistakes. And I'll say more about that in a little bit. But if you're in that setting, you're going to want to find, you're maybe going to want to have some tools available to you. More of those tools will be coming up too in future weeks. If you are in other settings, it's really the same process, depending on what kind of person you're working with and what kind of uh, diagnoses or life circumstance or whatever. If you're doing couples work, you're going to want to probably have some assessments for couples. If you're doing, I don't know, substance use work, you're going to need, obviously, you guys get it. So, having a library of things that are going to be relevant to you probably be important. Does that mean you need to have a whole library relevant to every subject and topic and person and demographic? No, not at all. But you may want to start collecting things that seem relevant. And if that changes in the future, so what? Collect again. Not a big deal, right? You can switch hobbies. Um, Another topic to think about is completely different, but these are sort of just random thoughts coming out at the beginning here. If you're going to be paying for tests, and this is largely focused for people who are not going to work for an agency, because many people want to start their own private practice. They get out into private practice and then find out, oh, there's a lot of expenses that come along with owning a business, and assessment tools are one of them. If you work for an agency or some sort of company or something, you may probably have access to some tests, or there might be a time where they say, well, we need to secure this grant or um, report on whether we're spending our money wisely. So we need tools to show that clients are making progress or whatever the situation is, then they'll provide those for you. But transferring expense is something that you'll have to think about if you're a private practice business owner or if you're being asked to develop a protocol of what tests you use and how much does it cost. It's just something that you'll have to think about. Another thing in that thread that I want to talk about too is right now, probably most of you are focused on how am I doing with clients? Am I learning enough about my own self and my process so that I can be effective with clients? Eventually, there will come a day when you're going to say, I think I got this like client interaction thing down, practiced it enough. I've done all my supervision hours. I'm now independently licensed and I'm ready to go. But I have all my clients coming from one referral source. So I should probably find another referral source to, kind of expand. If you were in that place where you want to diversify your clientele, this is something that people do. In my experience, it kind of happens between year 5 and 10 or something of their counseling career, where they say, well, I want to make sure I'm meeting different kinds of needs and I'm growing and learning different things. And people will say, well, how can I make money other ways, not just clientele, especially if I'm only getting $150 or 125, whatever it is from insurance, then I'm basically limited to how many hours I can fit in a work week and how much insurance will reimburse. But are there other opportunities where I can charge more for my time and demonstrate my expertise, that kind of stuff? So people will look into assessments because assessments can be expensive and you can charge other people a lot of money for them. Now, one of the things that came up in at least one of the classes was it's not that you're getting rich off of this. There can be opportunities to make good money on it, but oftentimes, if you're paying for your tests and you're writing reports and you're using time that could otherwise be used by other clients, it doesn't mean that you're getting rich. It still means that there's a kind of upfront, or I don't know, overhead costs that are involved in assessment. But if you're only getting $150 for a client hour, and you can pay, I don't know, charge or like a $500 for a, a 1.5 hour to 2 hour assessment plus report writing time, and some other things that go along with it, you're still making a little bit more money. But then you can do some things like either pocket the money and go to Cancun, or you can offset the cost of taking on pro bono clients. So some people will do this with ethics in mind. If I charge the rich a little bit more, I can Robin Hood that money into taking on some pro bono clients who couldn't otherwise afford my services, or something like that. So transferring expense to clients, that's a decision that as a business owner you would have to make, which all business owners have to make that, right? When the price of eggs go up, a chef has to charge more for a plate of eggs at the diner. It's just part of the way it works. So something to consider. I won't say anything more about it here, but that's just something that you may want to ask questions about as you get out into the world. Um, where you find your information and the quality of that information is something we've talked about a little bit in class. We can continue to talk about in class. I'm not going to say a whole ton about it right now because I think much of that will get gleaned out of what the future slides that I have coming up. Um, but the comment here is not just where you can get information about the formal testing tools, which is part of the research process that you'll want to go through, but if I just ask a question to a client, if I say, "How have you been sleeping lately?" and they say, "Well, not great." Well, how accurate of information is that? Okay, so how many hours of sleep do you get a night? How rested do you feel when you get up, et cetera, et cetera? I can ask those questions and get that information pretty readily. Readily? Apparently, I can't talk very well. I was told by a student the other day that I'm too self-deprecating in my lectures. And I was thinking about that a little bit afterwards. And she's like, maybe there's something to that. Maybe we should look into that. It's not a good look on you, Aaron. And I was like, maybe it's just awkward sitting in front of a camera in a room by myself talking alone. Because if you were here, a fly on the wall, you'd be like, he literally is talking to himself to a camera. It's a little surreal. Um, but also, hopefully it's just a little, it feels to me a little bit more humbling that there's not an air of perfection and superiority, because it's just a thing that I use as a tool with clients and students alike and whatever. So anyway, take that, Ariel and Dane, for teasing. I'm just kidding. Okay. Anyway, uh, we are trying to gather information as quickly as we can. Sometimes before we even talk to clients, they have gone through a few screening tools sitting in a waiting room, or we say we want to find out enough about all of the diagnostic categories. So tell me about your symptoms, not just the details of what you came here to talk about, but what I need to know. So there's all these different considerations of how can I get information in the most efficient way possible. And sometimes it's a screening tool up front. Sometimes it's a list of questions we have before people really dive in, kind of after our informed consent talk with our clients, that kind of thing. That is a decision that you get to make. Your style, how you want to gather information, what information you need. But part of the reason for using tools is it structures our questions and it gives us an opportunity to find out more things quicker so we can just kind of get it out of the way. So more conversation to have there, but we'll kind of save that for later too. Okay, so let's get into some of the nuts and bolts of selecting assessments. One of the things we need to consider, obviously, is what kind of information we need. If a client says, I'd like to see they make an appointment. I'd like to see a counselor for, I just feel anxious all the time and I have these tendencies that get in the way, these habits that I just have to perform. They get in the way of me living my life. I might be thinking, that sounds like maybe some anxiety stuff going on, maybe some obsessive compulsive kind of things, whatever. And already in my head, I have a sense of what I might be working with here. And so I can know that these are the tools that I can go get to make sure I'm ready for whatever. Or client comes in, you talk to them, session two, then you have something ready that's even more specific than that. So that's usually kind of what I do if I ever need to. Quick little side note about that. I don't always use tools. In fact, I don't use them all that often, depending on the role that I'm in, because I haven't been in jobs where I've really had to do diagnosis a whole lot. a lot of the time I'm doing more of that humanistic therapeutic interaction with people where we don't really have to name the problem. We don't have to label it something, especially not label it a DSM diagnosis. And they can say, I just feel ugh. And I say, ugh, that is not a diagnosis. We don't talk like that. No, I'm kidding. That's not what I say. I say, oh, that sounds painful. Do you want to talk about that? Is there a word that you want to give to it? That pain that you experience is not a diagnostic category, but it is very real to you and it hurts. And we don't want that to hurt anymore. So, uh, that's the kind of assessment that I'm doing is what is the pain? What do we want to call it? Where does it live? How does it show up in our body? How does it get in the way of our functional ability to just live life? How does it get in the way of our relationships? Those kind of questions are part of my assessment when I'm talking about stuff with clients. So, um, anyway, if I know that's the kind of information I need, then I am going to go in just saying, I know I'm looking for pain. I want to see how it impacts life. Sometimes if I'm in a role where I have to diagnose, I'll bring some tools in, etc. So you'll find that out later on as you get into your own practices, how much of what kind of information you're going to need. Okay. Um, what do you already have available? There's a list right here. I'm not going to go into it too much, but do you read records before you go in to see clients if you have availability up to them? Or do you wait till you've met with them, make your own first impressions, and then read what other people have already written as part of their file? That's up to you. You have an intake interview done by somebody else. That's sometimes a possibility that people have. Is there collateral information, something from a school, from a parent, et cetera, et cetera? So there's sometimes all kinds of background information that you have available to you before you even start. So lots to say around that, but it's really hard to talk about that unless I know specifically what kind of site you're working at. Just to give some semblance of an example, if I'm working in some kind of corrections or I'm having a client court ordered, I kind of want to know what their situation is. Is this their fourth DUI? Is it their first one? Are they self admitting to some treatment facility because they're concerned about their level of impairment? Or, it makes a big difference to what goes on in the session. Um, in other settings, just not so much. People make an appointment, shows up on my calendar, and I just come in and I say, "What's going on? What hurts?" When I worked in crisis, I'd get a phone call from the ER doctors, and I'd go into the ER, and they'd say, "Right this way. He's back in this room." And I'd pull back a curtain, and there's some dude sitting there, and when I say, "Hey," explain who I am, and I have no clue what I'm walking into. No clue. Oftentimes I kind of know that they're looking for some inpatient treatment, but not always. Sometimes people are suicidal, sometimes people are psychotic. It just really depends. And you just didn't know. And so you couldn't prepare for something like that. And that's just part of the work. You get to meet people where they are. Okay, I've already kind of talked about number three, determining methods for obtaining information. That's going to be an ongoing thread throughout, so I'll stop. I won't really say much about that. One thing I am going to do is I'm going to pull up one of these websites, PAR and Pearson. These are websites that sell tools, and I've brought them up in class, but I'm going to do it one more time here just to show you. And I'm going to pull it over from this other side. Sorry, you can't see it. I have three screens that I use when I'm doing this. So I have one down here, one right there, and one over here. Okay, so let's say I want to look for something related to, let's do a biopsychosocial or personality inventory. The 16PF, this will be a good one. So I'm going out, I'm looking for a test. They have all these different kinds of tests, and here are the prices of these tests. One of the things I think is kind of fun to do for classes is if you can find like a test report. Sometimes they have like sample reports. Of course they're not going to show me product details. Maybe I should have prepared this oh, here we go. A sample interpretive report. This can give you a really good sense of like, is this a tool that I want to use? See if I can pull this up fast enough. Here, I'm going to pull it off screen so I can actually get it open. We're not going to dig way into this, but I'll just sort of show you a little bit of what this looks like. So if I go on to Pearson and I say, I really need a test for such and such, and I don't have the manual obviously, but I can look at kind of what the output looks like. And I'm like, oh, do I need a test to understand extroversion, independence, tough mindedness, self control, anxiety, et cetera, et cetera? Do I need to know about that stuff? If I do, I can look into these and then I can say, yep, that's a test that I think would be interesting to me. And you can call people. I think you can still call people and ask them questions about it, whatever. But so that's a really good way to find tests. They do cost money. And this is one of those places where, especially if you are sort of entrepreneurial and you work in a private practice and you say, how much is this going to cost me? How much can I charge for it? How long would it take me to make that money back? And what utility does it have in my work? So that's something you can play around with. These have been around for a long time. They use that same ABC level of education thing. So most of you will have access to level A and B kind of test, and it says usually very clearly on there. I'm not going to go back to it now, but unless I can see it really fast, where they would say that. No, I can't. So sorry, but uh, those are good places to look for tests. Google searching is good, but it's also really hard because it like you can just find anything. Somebody, Jason, came up to me after class or in between a break or whatever the other day, and he's like, "Look what I found! It's found the MMPI on the Wayback Machine." If you don't know what the Wayback Machine is, it's like snapshots of websites that have long since been passed, but there's still a record of those old websites online. So if you want to see what Amazon looked like in 2013, you can go back and find out. It doesn't have the entire internet, so links don't work, but you can still find things like the MMPI and all the questions that showed up on the internet illegally. Don't do that, of course. Now the cat's out of the bag, of course somebody's going to go look for it. But it's just hard to find things, and you don't know the quality of things. You don't know if the questions are accurate. You don't know where those tests came from. So like whenever people say like, "What do you do? Just Google things?" and I'm like, "Yeah, kinda, but maybe not." You know? There is another thing called the Mental Measurement Yearbook, which is a very dense encyclopedia-like book that has all kinds of tests, and you can test tons of things. But oftentimes, some of those tests are the ones that are developed by researchers to find a very specific, like, cognitive function or do something for research purposes. But whether they have clinical utility is kind of questionable, but it's there. If you ever need something, like to understand something really specific, you can do that. If you look up articles on whatever condition you're interested in, let's say I want to learn about trichotillomania because I have a client who's pulling hair and I want to know if there's an assessment for that. This one you probably wouldn't, I'm guessing you wouldn't find a whole ton because you probably don't need a whole ton because you can go to the DSM and make a diagnosis relatively easily. But nevertheless, if you go to the research literature, go online, go to Google Scholar, or if you have access to library databases and you look for that diagnosis and you say like assessment tool, even if you don't say that, just find articles on it. And oftentimes you can find out what researchers are using to determine whether, to do studies on that disorder. So research literature is not just like articles about the assessment tool itself. It's about the condition and the tools people use to understand the condition. That's a possibility. Um, Professional organizations, your personal network is probably your biggest resource, although it's usually limited. I find that therapists in practice, they know what they know because they know who their clientele are, but beyond that, they don't care what tools are available for people that they don't see. So you'll get as much knowledge as that one person holds, which is great because then you know what happens in practice. If you are not around professional organizations like I don't know, the American Counseling Association, the American Rehabilitation Counseling Association, the lots of these organizations, if you're a member of them, they oftentimes have resources or forums or something like that where you can ask people questions like that. Um, Facebook groups, these are kind of losing their utility right now in 2024. I think I see less and less of these conversations happening about um, like clinical questions. But nevertheless, whatever social media you use, there may be a community there. Professional listservs, colleagues, of course, textbooks can sometimes be, although us academics, some of us are not necessarily in tune with what is most current in practice and what diagnoses people are testing for and seeing out in the real world in real time. And textbooks take a little time to publish, and we get out of practice, and so it does. You do want to be a little careful with textbooks, just the same way you're careful with searching the internet. You know, there's still a lot of good stuff in there, but knowing what you're getting, I guess. Okay, I'm gonna move a little faster. I think I'm talking too much about these things. Um, Consider culture and diversity concerns. These are conversations we're having in class. I'm not going to go way into it, but when you're buying a test, it's one thing to buy a test that seems good for you and how much it costs and whether it works for you. It's another thing to know if the test is actually good for your people. Should be a primary concern, really, but it probably begs, or it's worth mentioning here anyway. Uh, and then I'll just skip over the last one: evaluate and select an assessment instrument or strategy. Of course, I think I've already said that. So how do you do that though? That's a good question. Here's some details that I don't think I'm going to spend a ton of time on this, but what's the purpose of the instrument? These are some questions you can use just to determine whether this is a good tool or not, essentially. Who's the intended population? So it kind of goes to that norm group question. If you, I don't know how this works exactly, but what I would probably want to do is if I knew what I was trying to buy a tool for, if I went online to Pearson or PAR or something, and I didn't have the manual and I didn't want to pay for the manual, I would probably call their customer service and say, "Can you tell me about the norm group or the norm data for this, or give me any resources?" Or I'd go look online first and find out if there's any studies done about it, because oftentimes you could find studies about assessment tools before they're published that sort of through that norming process. Um, I would probably start there too if I was really concerned about a specific population of person that I'm working with. Just to give an example of that, we often think of cultural background as something that's sort of a limitation of the old white guy assessment tool. But one of the bigger ones that has been relevant in my life has been traumatic brain injuries, whether these or things like Down syndrome and things like that, whether these tools have been used, normed, and validated for people with different kinds of disabilities, because disabilities can be so different and show up so different in people's lives. And then when the tool is used, it's not necessarily working for that scenario. It's like saying I make furniture and I have a hand plane, and so I use this to shave wood flat, and I have this very specific tool, but then I am trying to make a log cabin and I have this fine woodworking tool and I'm trying to use it and it's just not working, because log cabins are a lot different than fine Amish furniture or whatever it is. So uh just something to check out. Um Reliability, yes, we talked about that last week. Validity, yes. The manuals, how much information manuals give. Some manuals are very deep, very dense, and very thick. Some are very skimpy on details, and they don't really provide a lot of substance. So you determine what works for you and how much is enough, but checking out the manual in advance is a good idea. Um, by the way, in advance, not of buying it. Sometimes you have to buy them, but checking out in advance of using it with clients. That's kind of pretty important. Uh, in the manuals, you'll see too, as we get some practice with these things, the manuals should provide a step-by-step administration process, how to score and how to interpret. You may not get all that you need from interpretation, because you should know something about like the diagnostic criteria or the population you're working with, or something about the condition maybe, but you can at least find something about like samples of what interpretation looks like, and then you can use your expertise from outside of that to incorporate it. So um I think that's pretty much all I want to say. You can read the other ones here. There's nothing really special about them that we haven't already talked about or something, but I do have this note here to show Carl's email. Carl's the author of our textbook, Carl Shaparis. And I was on a listserv one time, and somebody was asking a question about, should students be using these kind of things, or should our counselors qualified to use XYZ tool? And there was a good A good hearty professional debate. Sometimes I like to call them nerd fights because I go to conferences and I hear people arguing, and I'm like, this is like the nerdiest thing that I've done in a long time. And it needs to happen and it's important. It's not like I'm making fun of it completely. But it's also kind of funny because sometimes they're really silly arguments that people get really passionate about. So this was not a nerd fight. This was just a good, hearty debate. But there was a talk about whether students are qualified, or counselors, I think it was, are qualified for to do B levels tests or C level tests. And it's kind of a nuanced conversation. But part of the email that I got was this, not, it was part of a listserv. So it came up in my email. And it was this debate whether, what was it? It was like, if we have, is education, formal education enough to use a test? In grad school, we get this really foundational training, like about the math and about the science and about sort of overall big picture stuff like we have here, but we don't often use all the different tools that we're going to need. There's kind of this expectation that either you'll do that in supervision or you'll get it in practice, or the foundation is enough for you to go out and start using some of the tools. Other people argue that if I haven't used this tool and done it with a client, I can't just pick it up and start going. Otherwise, it's going to cause damage. So it was one of those debates, and I have it somewhere. I just don't know where it's at. So for the sake of time, I'll skip through that one. As you start thinking about how you're going to administer these things, it's not just about like, do I know my competency level? That's usually one of the concerns of students is like, I'm so unfamiliar with this. I don't even know where to start. Do I read off of this thing? What kind of question do I ask? And those are the things that we're probably thinking about right now. But as you start getting comfortable with interaction with clients and saying, I could pick up a tool and probably work through some of it after I learn it, go through it a couple times, like I could do that. 'Cause I'm not so worried about me and the client now. Now I'm trying to introduce this other thing, which adds complication. And when you do that, you're probably going to start thinking about things like, how long is this thing going to take? How easy is it to administer? Can I just give it to them, or do I have to read something, or do we work through it together? Is this a whole hour long thing? Those kind of questions are kind of important. How easy is it to score? Is it computer scored? Do I have to hand score it? How long is that going to take? I have notes to write, Aaron. I don't have time to go scoring assessments, you know? Um, Ease of interpretations, the format, the readability, the cost, all those kind of things. These are all going to be parts of the consideration process. Um, this is kind of more, does that say evaluate instrument? This is kind of the same thing. Sometimes the textbook was a little bit redundant, but there's kind of important things in both places. It feels probably unnecessarily redundant to me, but the method of administration, that's what this is about. And there's a table on page 183 if you want to go check it out. But is this a self-administrated tool? Can I just give this as a screener? Some yes, some no. We haven't really used one of those that you can't self-administer yet, in which you need to be part of the process, but they exist and you'll see more of them as we go. Is it a one-on-one administration, or can I do it as a group? Is there a computer version? If I do a computer version, do I have to have some iPad, or can I do it on my desktop? Is it Apple compatible or just Microsoft? Like those kind of things. It's like the logistical things here that we're talking about. Video administered, audio administered. How do I deal with accommodations if somebody needs them, et cetera, et cetera? There's a whole bunch of other stuff to take into consideration. If I want to give an assessment and I'm a provider and somebody says, I need an interpreter, do I know how to do that? Do I know how to hire an interpreter and that kind of stuff? So there's a lot that goes into this for consideration. As I say this, in my head, I'm thinking, oh my gosh, don't overwhelm them. It can be kind of overwhelming, which is why we have a little foundational practice here. I give you all these giant lists of things to be afraid of. And then when you go out and practice and you see these things used in practice, you're like, oh, okay. I can do that. You know, it just takes seeing it to build some comfort. So what I would encourage you to do is not get too worried about, can I do this, or is this okay for me to do right now? I mean, you should think about those too, but also think, somebody will help me with this, or I can still do this even if I'm not. Um, sorry, my phone started ringing. Even if I'm not ready for it yet, once I see it in practice, it'll be okay. Something like that. Okay. Um, Informed consent. When it comes to administering the test, part of what we'll get, I think we start next week on how to communicate some of this stuff to clients, is we're going to be talking about how do I talk about results. We've gone through a little bit of the stats. So, how do I talk about the statistics? Then, as we pick up these tests, we're going to say, how do I explain this to somebody in a way that's useful? If I'm going to do a Myers Briggs, I might say something like, this is a personality test. It's There's no right or wrong way to do this. It's just to understand a little bit more about the way you are so that we can talk about the way uh, how your life is going and how relationships work with other kinds of people or something like that. If I'm doing a diagnostic test, these are some questions that are sort of part of this anxiety disorder stuff, and you're wondering if you have a disorder, and this will help us figure that out. So the way that I present those things to clients are going to help inform them so they can make a choice about, do I want to move forward with this or not. Remember, assent is different than consent. So, how you talk to the kid who's getting the assessment versus the parent who's giving consent for the kid to give assent. Those kind of things you'll have to get some practice with too. But here's a list of things that you can talk about, and I'm not going to spend a ton of time going through these. Uh, the purpose of the assessment instrument, the criteria for selecting the instrument. No, I don't know why that's even there because I never talk about here's why I chose this one for you. You know, that is more relevant probably if you're doing like an assessment specifically for diagnosis, or you're using a battery of assessments. This one does this one does another thing. That's where that might be more relevant. But when I'm just talking about one diagnosis and I have the client and we're working together on like figuring out something, I'm not going to be like, I chose this one because, because I like it. And it said on the internet it got 5 stars. No, I'm kidding. They don't say that. But you know what I'm talking about? Like there's a way to do that that's not like, I don't know. You don't have to explain your process. You explain how it's relevant to the client. That's the point. Conditions under which it will be taken. I was talking to my own therapist a little while ago, and she was like, "Do you want to do this activity?" And I was like, "I mean, I guess. What is it?" So then she said, "Well, it'll take about, like, I don't know, maybe 15, 20 minutes, and we'll use these things, and I'll talk to you about this stuff, and here's what I'm going to say, and here's what you can do." And she walked through all the conditions in which this activity was going in which it was going to take place. Afterwards, I was like, "Oh, yeah, now I'm informed. I get it." So talking about the situation and what the client can expect, just getting them comfortable with their environment and surroundings is a good idea, because then they can make choices about, do I want to sit in a quiet room for 5 minutes or 20 minutes? Those are important things. The range of skills or domains to be measured, sure, if that's important in the scenario. Administration procedures and concerns, that's kind of like number 3. I just talked about that. Types of questions on the instrument. Sometimes it's good to walk through. If you're doing a more complicated assessment, oftentimes they'll have like practice questions, that kind of thing. If it's a 10-question Beck suppression inventory, some things I might say is like, let's go through this together. The questions are just going to be about things that are normal for the experience of depression to see if they resonate with you. That's all I'm going to say about something like that. Um, Types of scoring, methods, schedule for reporting results to the test taker. Those are, again, probably more important for more complex assessments. The longer an assessment takes to administer and to score, the more likely you're going to have to spend some time with it and then let them know what comes out of it. As you grow in your practice and your ability to understand things like diagnosis or the conditions in which people are coming in with, whether it's vocational concerns or career concerns or whatever it is, you'll get more adept at saying, after we do this, I can tell you as much about what I'm understanding as you want to hear, and the results of my assessment of how this is going or whatever. I can talk about that. And so sometimes you might need a little more time, sometimes you can do it right away. It really just depends on the scenario. um just to give you a sense of kind of what that spectrum might look like, when I talk to a person who's coming in just to get some regular old run of the mill therapy and they say, I'm having an issue with my mom and here's the scenario, whatever, and I'm feeling kind of depressed and I went to the doctor and they talked about medication, but they said I should come see you for depression. But they said I was depressed and they got me this medication. I say, "Are you depressed? Do you think so?" Well, I don't know, maybe, but I don't want to take the medication. I said, well, let's maybe look into that diagnosis of depression and see if this is an interpersonal conflict with mom that's showing up as depression, or maybe you don't even have depression and then we should just focus on mom. So we're maybe having that kind of conversation, and uh, we'll talk specifically about diagnoses. In which case, I'm just, my report is like, well, I don't think you do have depression. On the complete opposite side, when I was doing more forensic rehabilitation, like vocational rehabilitation forensic work, and I would be hired to do a vocational analysis of a person's work capacity or something like that. I would be hired by maybe like the defense attorney, and they would say, go have this interview. The plaintiff attorney is allowing you to spend some time with their client. You do this evaluation, whatever. And so then I would go do it, and there was an expectation that I'm not going to report on results because my client is actually the attorney. So I go back to the attorney and say, "Here's my report," and the plaintiff client doesn't actually ever, not the client, the plaintiff evaluee. There's language is kind of important. They don't actually get to hear the results, and they don't really care oftentimes in that scenario. So there's all kinds of scenarios, which is why it's so difficult to talk about these things sometimes. As far as administering assessments, build rapport. Remember that, and I haven't really talked about this for the whole 40 minutes that we've already been going, but if your job is to be therapeutic with a client, and we're talking about assessment here, part of what you want to practice or at least strive for is to be able to build that therapeutic benefit even though you're gathering information. It's one thing to say, I'm an evaluator and I need to gather information and determine a diagnosis for you, which feels to me, when I even say that, I'm like, feels like there's this chasm of separation between what I need and whoever the heck you are. But building rapport means building trust and relationship, which is the priority number one. So as I'm going in, I'm saying, hey, we're in this together. I want your life to be better. You want your life to be better. I'm here for that. In order for us to get there, sometimes we need to get this other kind of information. And here's why this might benefit you. Do you want to try that? Do you want to go there for now? And then we'll move on to some other things in a bit. And doing that, oftentimes clients will say, yeah, I see the path forward here. I understand what this might do for me and how it might help. In that case, I'm building rapport and doing my assessment and getting consent in the same process. So it takes a little bit of time to figure out how to say those words. But once you get there, you can do all these things simultaneously. For the purposes of learning, teaching, and learning, we break them down in these categories. But a lot of this happens kind of simultaneously. I'm going to get a drink of water. Hold on. Okay. Scoring. I think this goes without saying, but I need to say it. If you've never given the assessment before, maybe don't do it the first time on a real client. When I say maybe don't do it, don't do it. You don't want to be practicing on people where the consequences are real. Sometimes, if it's a pretty low impact, low risk kind of scenario, I'll say, hey, client, I have this new thing and I've never used it before, but it has very little potential for it to be harmful to you. And here's what it looks like. And then I go through that list of things, like, here's what I would do. And I'm wondering if you'd be willing to try it out. If there's low risk, low impact, those kind of things, I might try it out. Like, for example, when we get to the clinical assessment stuff and we go through the cross cutting measures, maybe this is the first time I've seen a client who has, oh, I don't know, like some specific phobia, but I've never actually used the cross cutting measures for phobia. Maybe I have for anxiety, for something else. But I use this brand new one in that cross cutting system. If you don't know what that means yet, don't worry, we'll get to it. But I haven't used it yet, so technically I'm not supposed to. But then again, I've used the other tools and I know kind of how to use those. And so it's probably okay, right? Use your best judgment. I know some of you don't have good judgment. I'm kind of kidding, but I'm also kind of not. I don't mean that in a derogatory way. I mean, you we don't know until we know, right? And some of you are so scared that you're just like, I'm not going to do it because I don't want to hurt anybody, which is great. But then you don't take enough risk. Some of you are like, no, this is easy. I got this. And I'm like, well, okay, maybe hold back a little bit. That might be a little bit too much confidence. So somewhere in there is a balance. And so when I'm flippantly or facetiously saying like some of you have poor judgment, I kind of mean it, but not for all of you. So it's individual of who I mean that to and why. Um, but practice on somebody if you can. Absolutely practice on somebody. Uh, some of these have the scoring is simple. It's on a computer. There's formal processes. Some of them, if you've ever done like the old school scoring where you go to the manual, you put this number in this box and transfer it over here, then you go find this chart, look over across the chart, you find this other number, put it back, and it takes a little time. It's a little tedious. I think it's kind of fun. Some people are really annoyed by it, but um, get some practice doing that so you kind of know what that is. You don't want to be making any kind of clerical errors on people's real scores. Um, Number three, what do I want to say about that? One of the things you're going to be doing plenty of. Actually, let me take a step back here. Remember in the beginning when I said there's the science part and the humanistic part? And the humanistic part, you're kind of feeling your way through things, you're sensing using your intuition and all of your background, sort of muscle memory from all of your experiences before and all your training. And you go in and you can just kind of sense something about people. That is something that should be trusted. And we should be able to hone that ability to say, like, you know what? I can empathize with your pain because I've felt it myself and I've heard it from other people and I get it. I get what that is. Sometimes you can do that. That is your professional judgment. So when you're going through an assessment process and you're scoring something and you see this data says this, but man, something just doesn't fit here. This is what I'm talking about at number three when I say some instruments require professional judgment. Maybe that's an understatement. Maybe we could say all instruments require professional judgment. But follow the procedures as you're supposed to. And then what you do is you get to report or interpret these scores within the context of other things that you know about people. And that's really important there. Second sentence here, just like in interviews, how do we control for bias? There's some stuff on page 190. You can check that out. Part of the reason we use standardized procedures is to control for some of that bias because we should not and cannot trust our intuitions all the time. We just get it wrong and we make mistakes, right? That's the whole point of systematizing something. So we have a consistent process to reduce the amount of error. That's the idea. Even still, find ways to reduce error. For example, I'm not going to spend a ton of time talking about this, but a little bit. If I'm having to make judgments on people and I just had a really hard session, and someone came in and they were challenging me and pushing my, sort of feeling those triggers and being emotionally reactive in ways inside, at least in ways that I'm like, this is bringing up some stuff for me. And then I go to another session and I have to make a diagnostic judgment or determine something about this client. One of my best defenses against my own bias and against my own uh, stuff getting in the way, whatever that stuff is having really good, solid, trusted people around me. So I can go say, can I just check this out with you? Because I'm reacting in a way that I don't feel is good for me, or more importantly, for them. So supervision, supervision, mentors, trusted colleagues, people that just seem to be grounded at times that you're not, that helps protect for that bias. Am I overreacting here? Am I being politically biased? Am I judging this person for something that is unfair? Those kind of things are really important to check out with other people. With that said, you're going to screw it up. You're going to make errors. It's okay to make errors. Hopefully, we can mitigate the consequences of those errors. The biggest way, in my humble opinion, to do that, maybe it's not that humble, maybe it's totally arrogant, but the biggest way that you can mitigate the errors is to own them, take responsibility for them, and correct them. If you find yourself saying, just erase it out and scribble it out, pretend it never happened. Or let's see if we can not acknowledge that. Let's sort of run from it. Or someone accuses me of making an error and I say, that's not me. I didn't make that error. I fight against it. Anytime you're having those reactive defensiveness, fight or flight responses, you're probably not responding in a way that's going to be wholesome and healthy for you. So own them, take responsibility, apologize. Don't live with that sense of guilt. If you can get rid of it, it might stick around for a little bit. Mistakes hurt and the pain lives. The faster you can get over it and get beyond it, better off you'll be. The more ways that you can prevent for those biases, find ways to prevent and correct errors, you're going to be okay. Because we make the mistakes. I still make mistakes and I hate it and I'm hard on myself about it. But I have trusted people around me who I get to ask, am I being too hard or is this just hard enough to help me do better next time? That kind of stuff. Okay. How many more do we got? Oh, it's the last one. Wait, 10 minutes. Can we make it? We'll see. I don't know. Interpretation. After you've chosen a test and then you've administered the test and then you've scored the test, this is where the rubber meets the road in terms of what am I going to do with this thing? How do I understand this? How am I conceptualizing this case or this client? Oh, excuse me. If I know the test and I know what the subscales are and what those things mean because I've done some practice and I've gotten comfortable with it, I know the terms and the language of the test. These things, I'm willing to bet that everybody in this class right now, you don't know this. You just don't, you're not there where you're like, I'm confident in the language of therapy. You're starting to know the terms and the language, but one of the things that's hard to get is where does this information go and who am I speaking to? It's one thing we'll get practice with in our final reports, final papers, is it's one thing to know what it sounds like in my head to talk like this. It's another thing what it sounds like from other people who are going to be hearing this and what they're understanding. So knowing the terminology and the language might make you feel or sound really smart to a bunch of people, but it's not going to land with them. So knowing the test, knowing how to translate that into useful information that other people actually understand and then can do something with, that's when this really starts to hit home. So when it says like know the terms, it's not just build your vocabulary so you sound completely useless to everybody else around you, but know the terms and know what they mean and understand the spirit of what the test is for so that you can say, here's what we're taking away from this. It's hard. It's hard to do, but it's a goal that you can set for yourself. Know how to read the score report, percentiles, T-scores, etc. We've been practicing that. Seems like most of us are pretty solid in knowing how to do that. Still is just going to take a little bit of practice. How do you talk about these things and get some experience using them? We don't make single determinations based on a single test score. I think when we talked about the GAD-7, it said probable diagnosis if they test positive for 7 of these questions or whatever it was, or you can give the first 2 and still make a probable diagnosis of anxiety. And all of us were like, oh, that sounds awful. You can't do that. That's not enough information. And maybe not. I'm not going to make a comment on record here because there are some situations in which it's appropriate. Others, it's totally not appropriate. But you don't just, if you have not seen a person and all of a sudden you're getting these test scores and it says like, oh, probably anxiety. And you're like, well, okay, diagnosis, that's bad, right? Like that's obviously bad. We don't want to do that. We want to talk to a person, understand how they describe their condition. We want to understand a little bit about their background and what they're, what they're trying to get out of counseling and all that kind of stuff. So we cannot take one piece of data. We need to have multiple ways of gathering information. And if it's just a test and a conversation, that's a good beginning, and that might be enough in most cases. But the more information you have, the better of a decision you're going to make. I don't want to say that the more information, the better the decision is. No, wait, I just said that. Now I'm getting myself twisted around. You'll make smarter decisions the more data you have to consider that you can then filter through and say, okay, I have a whole picture here. I can see, I'm seeing more of it. So I make wiser decisions. It doesn't just mean that like more is better. And you're throwing spaghetti at the wall, just say I have this data and this data and this data and this data. It helps inform to making a wiser decision. I think I might have just butchered the way I said that. I don't know. It's starting to not make sense in my head. So if you're confused, let's just forget it never happened. Erase the last few minutes of our lives, and we'll move on. I think you get the point, though. We don't want to use too little of information. There's also a dangerous other side of trying to get too much and assuming we have it's the more is better. Whatever. Uh, Sometimes you'll get interpretive outputs that are computer generated. Be very careful with those. Sometimes they're helpful, sometimes not so much. For the majority of the kinds of work that most of us are going to do, those interpretive reports are probably going to be not very consequential. I'll see what I mean in a second. Or we're not going to get interpretive reports at all. If you're using the cross-cutting measures to make a clinical diagnosis based on the DSM, if you're using the Beck's Depression Inventory, the PHQ, the GAD-7, using any of those kind of things, you're not getting interpretive outputs. You're getting a score, and then it says mild, moderate, or severe depression or anxiety or whatever, that kind of thing. So there's no like report that says. But if you're using the Myers-Briggs, it says, well, if you're an ISTJ, here's the kind of person that might fit you. Here's a classification or like an explanation of your personality characteristics. And most of us have gone through those and we're like, yeah, I get that one, but that part doesn't really fit. And so, like, is this garbage or is it good? And that's something that we get to, as clinicians, we get to be cautious about those things and oftentimes work through them with clients. It doesn't mean this is who you are. It's here's some information. How does this land with you? Does it resonate with you? Does it fit your understanding of yourself? And so then we can collaboratively sort of like rewrite it, so to speak. If you're using things that have high consequence, like for example, the MMPI, or if you're doing a vocational assessment that has an output that kind of describes a person's sort of work personality or work profile, and then you're using that to make employment decisions, that's kind of scary and you don't want to do that. So you're going to want to take those verbal reports or sorry, written reports and look at them, consider them, but write them in your own words based on your professional knowledge that you can stand behind. You don't want to just take somebody else's thing and be like, well, okay, copy paste. There you go. Anything you get out of Chat GPT or, some AI tool that says, here's what you should write. Be cautious of copying and pasting. I don't know why that's so hard. We all know it, and yet it's so tempting to do it. Because even I find myself being like, this would make my life easier, but is it the right decision to make? Having those kind of questions in my head still, and I'm like, oh gosh, I know I should be doing this the long way, but I'm so tempted to do it the easy way. Um, and then use scales within tests to compare to each other. This one, I almost have to show you an example of this in person or something, but I'll do my best to explain it, and it's the last thing. Sometimes you'll have a test that doesn't just give one diagnostic outcome. You'll have a test that has multiple different subscales. So I think we've practiced this a little bit in class where you'll see something that says person has, low withdrawal rates. They're reporting high generalized anxiety, but low phobic anxiety and high somatic complaints. And because we see anxiety and somatic complaints, we're like, yeah, somatic complaints show up with anxiety. But if I heard somebody say like, I'm scoring high on somatic complaints, but also I'm not really anxious. I'm not really depressed, but I am. What's a good example? I don't know. I'm having these. I'm hearing these things, these like suggestive paranoia kind of things, and I'm thinking schizophrenia doesn't necessarily doesn't correlate, doesn't have a relationship with somatic complaints. So it almost seems like there's two separate things going on there. So I'm using those subscales to either corroborate the information to make sense of it together or to differentiate. Maybe I need to make a referral for something else or ask about medical history to see if there's a history of chronic pain or something else, or heart conditions or whatever it is. So hopefully that makes a little bit of sense of what that means there. Okay, that's it. Another one in the books. What are we at? 59 minutes. How did I almost nailed that 1 hour mark. Should I talk for 45 more seconds? No, probably not. Okay. Well, thanks for hanging in there with me, you guys, and I will talk to you in class. See ya.